Hi, and welcome to your Peripheral Vascular Surgery preview. I'm Mark Sowers. As usual, we're going to start with anatomy and, my favorite, physiology. As soon as the blood leaves the heart and enters the aorta, we're now entering the peripheral vascular system. And this is actually a good place for the body to sort of sense and figure out just what's going on with the blood. So right along the aorta and up in the carotid artery, we have what's called aortic bodies. Now, these aortic bodies are little sensors, and they sense things like oxygen levels, carbon dioxide levels, pH levels, and right nearby, they're little baroreceptors, and baro means pressure. Think of barometer, you're measuring air pressure. So in this case, a baroreceptor is measuring blood pressure. So all this information is gathered right here at the aorta, and it's sent up to the brain, or to the brain stem at least, and telling the body what's going on with the blood. In the peripheral vascular system, we have arteries, capillaries, and veins. And as you can see here, there are some differences between those three items. The arteries tend to have a thicker wall. They're more muscular in the middle because they're going to contract and expand as blood pressure changes. Capillaries are very small. We're going to get to details on that. And then veins happen to have a thinner wall because they're just returning the blood to the heart. Both arteries and veins have three basic layers that make up the tube, the pipe of the artery or the vein. There's an inner layer, a middle layer, and an outer layer. And the names of those are the tunica interna, that's the inner layer. And you can see it's pretty similar between the arteries and the veins here. We have the tunica media, media meaning middle, and in this case it's quite different between the arteries and the veins. The arteries happen to have a big, thick tunica media. That's because there's so much muscle. There's smooth muscle cells in this tunica media in an artery. But in the vein, there's very little. There's almost no muscle cells at all in a vein wall, so the tunica media in a vein is very, very thin. And then the exterior wall is known as the tunica externa, external, externa, or tunica adventita in some books. Now, oxygen, carbon dioxide, nutrients from the blood into the blood can only pass through maybe a couple of cell layers thick before it gets so diffuse it can't pass through anymore. But most vessels, especially large vessels, especially arteries, have a really thick wall. That means many, many hundreds of cells thick. So any blood or oxygen or gas inside is not going to diffuse that far. So these tissues actually have their own blood supply that feeds them. They have arteries and veins and nerves that go into the wall of the artery, the larger artery or the larger vein. And this area is known as the vasa vasorum. So that's the blood supply that feeds the wall of the artery or the vein. Now, unlike arteries and veins, capillaries are really, really tiny, very tiny. In fact, so small they don't have a tunica media or a tunica externa. They don't have those outer two layers. They just have that one inner layer, which is the only layer in a capillary. And in most cases, it's only one cell thick. So capillaries, very, very thin. You can see sort of a cross section here, just a single thin cell thickness to that capillary wall, and the blood flows through the center. But to me, the most interesting thing about capillaries is that they're not solid. The wall is not solid. Now, I don't really like this picture here because it seems to show a solid wall, the cells sort of sticking together and all the cells border each other, and it seems like, it's a solid wall there. But in most capillaries, that's not the case. The cells sort of touch each other here or there, but there's often a gap. There's a hole in the wall of the capillary. There's a big old hole there. In fact, there are many, many big old holes between the cells of the walls of the capillaries. And that means capillaries are leaky. Stuff that's inside the capillary sort of leaks out of them all over the place. I sort of think of them like a long basketball net. Maybe you go to a fair or a carnival and you have these long basketball nets. You're shooting the basketball and it brings the basketball back to you through this long net. Well, a basketball net is a really good example of, in my opinion, a capillary. Because, yeah, there's some netting, there's some stuff to contain things inside, but there are all these holes in it. So You throw, say, a basketball through that, sure, the basketball is going to pass right through. Think of a red blood cell. It's going to pass right through that net and continue on to the other side, right? Okay, other large objects, such as, let's say, a soccer ball, football, those things are going to pass right through because they're bigger than the holes in the net. Even a softball, you throw that into a basketball net, it's probably going to pass right on through to the other side. But what about smaller things? Let's say we throw some golf balls into a basketball net like this. What's going to happen? Well, some of them will pass right on through, but others could actually fit through those holes, through those gaps in the net, in the capillary wall, which means they're going to leak out. And smaller still items, let's say marbles, or even, let's say what happens if we pour some water into this basketball net. Is that going to flow all the way through the tube to the other side? Nah, not at all. It's going to leak out through those holes. So the neat thing about capillaries is they sort of act as a filter. If you got something big going through there, let's say a red blood cell or many of the white blood cells or even some large proteins and platelets and things like that, they're just going to stay in the net and they're going to continue on down the capillary until it meets up with the vein and then continue on back to the heart. But if you have smaller stuff like electrolytes, ions, even very small proteins, things like that, even some certain white blood cells, they're going to fit through those holes. These capillaries are going to be leaky, and it's all going to sort of spill out into the space around, outside of that capillary. So big stuff stays in the capillary, but little stuff like water and a few other things can leak out of the capillary. So what is this stuff that leaks out and where does it go? Well, I think it's essentially plasma. That's basically what it is. It doesn't have any of the red and white blood cells in it, or maybe a few white blood cells, but mostly it's just plasma that leaks out through these holes in the capillary walls, and it fills the space in between the cells. So you have the capillary, and then you have a cell over here. Well, there's a little bit of space between the capillary and the cell, and this space is known as interstitial or intercellular space. So this space is actually filled up with a fluid, which is basically plasma, because it comes out of those blood cells, filters through those holes, and fills this space with the fluid. So cells are bathed in this interstitial fluid, which is essentially plasma, that's leaked out of the capillaries. And that's how oxygen and nutrients and things like that are brought to cells. It sort of leaks out of the capillaries and it sort of surrounds the cells. It sort of flows through the tissue, this fluid, this interstitial fluid, bringing the nutrients, bringing the oxygen to those cells. And then what happens is it goes back into the capillaries. Again, those capillaries kind of have holes in them. So a lot of it goes right back into the capillary and continues on back into the venous system, into the veins. But some of this interstitial fluid, essentially plasma, takes a different route back. And this goes into the lymph capillaries. So wherever we have these leaky capillaries, which is pretty much everywhere, we're also going to have lymph capillaries. And what they're going to do is they're going to sort of act like a little vacuum cleaner. And they're going to grab anything that's sort of floating around in this interstitial, this intercellular fluid. They're going to suck up this interstitial fluid and anything else that might be in that interstitial fluid and take it back to where it belongs. So what might be in this? Well, cells die all the time. So cells break apart and there are extra proteins sort of floating around, little pieces of cells. Or maybe there's bacteria or maybe some other, I don't know, stuff gets into this interstitial fluid that you don't necessarily want to go back into the bloodstream directly, but you still want to clean it up. So that's what lymph capillaries do. They take all this used interstitial fluid and all out of the dirt and stuff, the dirt, quote unquote, stuff that happens to be in there, and it takes it to lymph nodes, which are then going to filter that stuff out and clean it up. So most people think of the circulatory system, the peripheral vascular system, as having arteries, capillaries, and veins, as you see here, but I think of it as a little different. I think of it as having a fourth component, and this fourth component being lymph capillaries and lymph vessels. So what's going on here? Well, we have blood coming down through the arteries, and that contains, the blood cells and the plasmas and proteins and everything. It goes through the capillaries. Some of that plasma leaks out. Some of it stays in and returns through the vein. And all those large objects, the red blood cells, most of the white blood cells, the proteins, that's all going to return through the veins. But through the lymphatic system, that's where a lot of that extra plasma that sort of leaked out into that interstitial space, that interstitial fluid then goes into the lymph capillaries, becomes lymph at that point. It's still essentially plasma. It's essentially the same stuff. It's got a little bit of dirt and stuff in it. And that's going to return through the lymphatic vessels to lymphatic nodes or lymph nodes, which are going to then filter and clean out all that dirt, dead cells, bacteria, things like that, stuff that you don't want in your circulatory system. It's going to filter all that out in these lymph nodes. And then it's going to take that clean, that purified plasma, essentially, lymph, same thing, basically, and it's going to put it back into a large vein where it goes back to the heart. So understanding that capillaries have holes and, they're kind of leaky and the big stuff still stays in them, but the little stuff, especially water and stuff like that, is going to leak out of them all over the place, sort of brings up a question. All right, so we have blood pressure, right? I mean, blood pressure is what pushes the blood through the arteries and into the capillaries, right? But if we think about capillaries as having holes in them, that they're leaky, that stuff just flows right out of them, and essentially that's what happened. The small stuff, the water, flows right out of these capillaries as though the walls are barely even there. Think of it as a leaky system. So when you get down to capillaries, you've got water leaking out of the system all over the place. So what happens by the time you get to the end of that capillary? Remember, blood pressure was pushing that blood through the arteries, and it's pushing that blood into those capillaries. But if the capillaries are so leaky, where does the blood pressure go? You've released all that pressure. So at the end of the capillary, where's the blood pressure? There's no blood pressure left. And this creates a problem. Now, to answer that question, I'm going to have to go off on a little bit of a tangent here that I think is really interesting, but I will admit is not quite directly related to surgical technology, which means there's less likelihood that this is going to appear on a test somewhere. So if you're in a hurry, go ahead and fast forward down here at the bottom to about the 30-minute mark of this video, where I start talking about peripheral vascular terms. But if I've piqued your curiosity, hang on, because we're about to go down a little rabbit hole. So first, let's take a look at a graph of just how the blood pressure changes as the blood moves through the system. Now we're going to start over here on the left. At the left edge, that's going to be the heart. So that's where the blood pressure is going to be the highest. And you can see these little spikes up and down and up and down. That's as the heart beats. Every time the heart beats, it contracts. It's going into systole. That's the beating, the squeezing of the heart. That's where the blood pressure goes up. And when the heart relaxes, it goes into diastole. That's when the blood pressure is going to lower a little bit. So you see this spike and drop and spike and drop every time the heart beats. And you see that in the large arteries. And as we get further and further away from the heart, as we go from arteries down to arterioles, which are smaller arteries, the blood pressure continues to drop and drop. And that cycle between systolic and diastolic pressure gets smaller and smaller and smaller, and the blood pressure gets smaller and smaller. So by the time you hit capillaries, which are leaking fluid all over the place, there's really not a whole lot of blood pressure left. And in fact, by the time we make it through the capillaries and into the venules, small veins, and then into the larger veins, there's almost no blood pressure left. So that leads to a really important question. If there's almost no blood pressure left by the time the blood reaches the veins, and I have veins in my leg, well, how is that blood going to make it all the way up my body, all the way up to the heart? How's it going to work against gravity to get all the way back up to my heart? There's no blood pressure left. It's not like the heart's squeezing and it squeezes all the way through the system and back around. That's not what happens. There's no blood pressure left by the time you hit those veins. So something else other than blood pressure is got to pump that blood back all the way up to the heart. And this process of returning blood through the veins to the heart is known as venous return. Venous for vein. So venous return, that's a process that returns the blood through the veins to the heart. And it's a complex and, I think, absolutely fascinating system. So to understand venous return, you have to understand one key fact. There is a very significant difference between arteries and veins. Although arteries, have the thicker wall and stuff, but unlike arteries, veins have valves. Yeah, valves, just like the heart. The heart has valves, right? We talked about that previously. The valves open and close in the heart. And when they're open, the blood's flowing through just fine. And they just sort of, it's a little flap and it just stays open. But if the blood tries to go backwards, those valves close, they slam shut, and they block the blood from going backwards. So through the heart, the blood can only flow one direction because of the valves. It can't go backwards. Well, veins act exactly the same way. Veins have valves. There's lots and lots of valves. You think of the 4 valves, you know those valves in the heart. But throughout the veins, throughout the venous system, there are hundreds, thousands of these little valves all throughout the system. And these valves allow the blood in the veins to flow in only one direction. And that's key to getting the blood back to the heart. And to pump that blood through those veins, through those valves, one valve to the next, there are 3 major mechanisms. Now, although veins have a tiny little bit of smooth muscle in them, it's really not strong enough to squeeze that vein down and sort of push the blood through and along to the next valve. But most veins run through or past skeletal muscle, the big muscles, say, in your arm or in your leg, right? So what happens when you flex your arm or flex your leg or pull on any of those skeletal muscles squeeze down, right? And what they do is they squeeze the veins nearby. And when they squeeze the vein, the blood can't flow down because of the valves, all right? The valve has closed at the bottom, so the blood can only flow up. So as those muscles, the skeletal muscles, the regular muscles in your body, as they squeeze, they press on the vein, which pushes the blood up through the next valve. And then as those muscles relax, the vein opens up again and the blood's going to want to flow back, but it can't because there's a valve there blocking it. So I think of the valves as kind of like a lock system. Think of the Panama Canal, which is what I'm showing you here. How the Panama Canal is able to raise boats up higher and higher and go over the mountain as it goes across Panama. What happens is the boat goes in at one level and then the valve, let's call it, closes and then it raises it up to the next level and then it goes through the next valve and then that valve closes and it raises it up and it keeps stepping up and that's how the boat makes it all the way up to the top of the mountain. Well, the blood in your veins does exactly the same thing. It goes from one valve section to the next valve section to the next valve section. And every time one of those little sections gets squeezed, it's going to push the blood up to the next section. It's going to wait around until that section gets squeezed. And then it's going to push up to the next section. So it's like a lock system. It steps its way all the way up, all the way back to the heart. So the first mechanism to get blood to return to the heart is skeletal muscles squeezing on the sides of those veins, pumping the blood up to the next level and then to the next level, all the way up to the heart. And think about this. That's why stretching in the morning feels so good, right? You wake up, the blood hasn't been flowing a whole lot because you haven't been moving. Your skeletal muscles haven't been moving so much. So the first thing you do is you stretch. And what are you doing? You're stretching the muscles, which by itself feels good, but you're also squeezing the veins in your arms, in your legs, in your back, everything. When you're stretching out, you're squeezing those veins, pumping that blood out of there, making room for new blood to come in, which contains more nutrients, more oxygen that those cells in those areas were kind of lacking for a while. And all of a sudden your cells are getting fed with this new nutrients and new oxygen and they feel better. So stretching not only makes the muscles feel better, but it makes all the cells in that area feel better. And that's why stretching feels so good. And that's the same reason that massages feel so good. When somebody's pressing on your skin, pressing on those muscles, not only are they stretching those muscles out, but one of the main things that they're doing is they're squeezing those veins. They're pressing down on those veins, pumping the blood through the veins, pumping the old blood out, which allows new blood to come in, feeding and giving oxygen to those cells. And it just feels so much better because you have happy, healthy, well-fed cells. So stretching, massage, exercise, anything that's going to put pressure on those veins to get that blood moving is going to make your body feel better. So speaking of stretching, when you wake up, let's talk about sleeping a little bit, because what happens when you're asleep? When you're asleep, you're not doing exercises, you're not walking around, your skeletal muscles aren't contracting and relaxing and putting pressure on your veins to pump that blood. So how does the blood flow when you're asleep? Well, that's where mechanism number 2 comes in. Now, mechanism number 1 was the muscles themselves squeezing on the outside of the veins that pumps the blood through. But mechanism number 2 actually comes indirectly from the heart itself. Now, again, as you're asleep, your skeletal muscles aren't moving, you're just sort of laying there, but your heart keeps beating. And what happens is your heart keeps beating, and remember, in your arteries, the blood pressure goes up and down every time your heart beats, right? Well, here's the thing. Arteries and veins and lymphatic vessels and nerves all tend to follow the exact same channel through the body. So all these different channels leading all over your body tend to contain those 4 things: arteries, veins, lymphatics, and nerves, which means arteries and veins are most of the time side by side. They're right next to each other. So think about this. The heart's beating. The artery is getting more and less pressure every time the heart beats, right? So the artery is expanding and contracting, expanding and contracting. So here's a vein right next to it. Every time the artery expands, it puts pressure on that vein. Expand, contract, putting pressure on that vein, and it's not a whole lot, but it's enough for that blood to squeeze that vein just a little bit to pump it along into the next segment of that vein, and then it can't pump back again because those valves are there. So that little bit of pressure by the artery right next to that vein is enough to pump the blood along. And again, as I said, this is not a whole lot of pressure, but it's just enough, especially when you're asleep. Because when you're asleep, you're lying down. So think about your legs here, okay? Your legs are at the same level as your heart when you're lying down. So even if there's just a little bit of pressure on those veins, it's just enough to get that blood flowing horizontally up to your heart. Which then leads me to a big point. As long as you're laying horizontally, yeah, your blood's not flowing quite as much as it would if you're up and you're active, but it's still flowing because the arteries are squeezing the veins a little bit and pumping that blood to the heart. But what happens if you're sleeping vertically? Let's say you're stuck in economy class in an airplane for many, many hours and you take a nap. Well, you're not horizontal. Your legs are not at the same level as your heart in this case. Your legs are way down here. They're much lower than your heart. And now you have gravity pulling that blood down. So even though the artery is sort of squeezing on that vein a little bit, it's not quite enough to get most of that blood to return. So the blood in your legs, especially way down in your legs, tends to stagnate because it's got a long way to climb to get all the way up to your heart. And that little pulsating artery next to it is not quite enough to do it. So what happens? Well, this is where you start to run into problems. Because as long as blood is flowing, you have all those platelets and everything else in there, and they just continue to move on and bounce along through the vessels. But when blood stops flowing, when it stops moving, one of the big things that it does is it tends to clot. So if you're sleeping vertically, say in an airplane seat, and your legs are far below your heart, that squeezing is not going to be enough to get that blood moving. That blood's just going to sit. And if it sits too long without moving, it's going to start to clot, and that's going to start to form thrombuses. And what thrombuses are blood cells clotted together into one large bulky mass. And when blood clots along the side of the vein and sometimes in the little pockets of the valves, that's known as deep vein thrombosis. And this is a very serious condition that many people will have if they're on long airplane flights. So what happens is the blood clots, it forms these thrombuses, which sometimes can break off. And if a thrombus breaks away from where it was attached, it now becomes an embolus, which is a floating blood clot. And it's going to float along through the circulatory system until it gets trapped somewhere else. So if we have emboli that form in the veins of the legs, let's figure out where they're going to go. So we go back to our diagram of our heart. So those emboli that start in the legs of the veins, let's say you have an embolus that's this size, all right, but they're going to go into veins that get bigger and bigger and bigger as you approach the heart because the veins get bigger and bigger. So an embolus this size is going to continue to flow through those veins just fine because they keep getting bigger and bigger, right? They're not going to trap that embolus. So where's it going to go? It's going to go up the inferior vena cava. It's going to go into the heart, into the right atrium, where it's going to get pumped into the right ventricle, and then it's going to get pumped out into the pulmonary artery. And from the pulmonary artery, it heads into the lungs. And that's where we start to get problems. Because as that pulmonary artery branches into smaller and smaller arterioles, as it spreads the blood around the lungs, those pipes get narrower and narrower. And here comes this embolus that's bigger now than the pipes that's carrying it. And it's going to stop. It's going to get stuck. And that means it's going to block the blood flow in the lungs. This is known as a pulmonary embolism. So deep vein thrombosis and then, in extreme case, pulmonary embolisms are a risk factor for sleeping in an upright position, especially, let's say, on an airplane or something like that, for a long period of time, which is why if you're on an airplane, and if you catch a little bit of sleep, you're going to want to wake up every couple of hours, stretch out, walk around the airplane a little bit, get that blood flowing through your legs so you prevent the clotting from happening in those veins of the legs. So every couple of hours, you're really going to stretch it out, walk around, and get that blood flowing again so it doesn't clot in your legs. Okay, so we've covered two of the mechanisms getting blood in the veins to return to the heart. One is skeletal muscles pressing down on the sides of the vein, pushing it through. One is arteries pressing against the side of the vein, pushing it through. So that's number 1 and 2. And number 3, well, we kind of touched on this a couple of lectures ago when we were talking about breathing. So if you didn't see that lecture, go back and watch it. It's a lot of good information in there, but I'll briefly go over what we discussed. So I showed a little demonstration of how the lungs work and how the diaphragm works. So I had this little jar and it had a pipe that goes in, let's say call it the trachea, and it went into these two balloons, and I had a diaphragm at the bottom, and when I expand the diaphragm, what it did was enlarge the space in that thoracic cavity, and that lowered the air pressure, which pushed air through the trachea and into the lungs. So every time the diaphragm contracted, it lowered pressure in the thoracic cavity and it pulled air in through the trachea and into the lungs. And that's how breathing works. But here's where it gets interesting. The trachea is not the only pipe that leads into the thoracic cavity. In fact, there are many, many veins that lead into the thoracic cavity. And guess what? Every time you breathe, you're lowering pressure in the thoracic cavity. So you have blood in the vein over here, and then you lower the pressure on this side of the vein. Well, guess what's going to happen? It's going to pull the blood through into this section. So it's going to pull it through this valve into this now lower pressure area, which means the process of breathing, every time you take a breath like that, you're lowering the pressure. You're not just pulling air into your lungs, but you're pulling blood through your veins, through your venous system, into your thoracic cavity, and that brings it back to the heart. And that, I think, is really cool. The process of breathing, not only does it bring air into your lungs, but by lowering the pressure in the thoracic cavity, it draws blood through the veins back to your heart. So here's something to think about. You know how to do CPR, right? You're doing chest compressions on somebody if their heart stops beating. Well, how does that work? Well, obviously you press down on the heart, and the heart has valves, which means you're squeezing the heart and the blood can only flow one way. So it can only flow out of the heart one way. So by pressing on their chest, you're squeezing the heart and you're pumping the blood out of the heart. But that's not the only thing you're putting pressure on. You're also putting pressure on the vena cava and other veins in the thoracic cavity. Every time you press down, you're not just pressing on the heart, but you're pressing on these veins, and these veins have valves, which means you're squeezing that blood, and it can only go one way. You're pumping it into the heart. So when you're doing CPR, you're pumping blood out of the heart by squeezing the heart, but you're also pumping the blood into the heart by squeezing the veins near the heart and pumping that blood in. And that's why CPR is often so effective, not just because of the valves in the heart, but because of the valves all through those veins in that thoracic cavity. So just like if the valves of the heart don't close properly and they don't close all the way and blood can flow backwards through those valves if they don't close, that can cause a lot of problems. Well, if the valves in the veins don't close properly and blood can flow backwards through those valves, that can cause problems as well. And in fact, the biggest problem that it can cause is something known as varicose veins. And you've heard of that, right? You've probably seen your grandmother and she has these little veins on her legs or something like that. But varicose veins can happen in larger, deeper veins as well. So here's what can happen if there's a problem with the valves in some of those bigger veins. The blood will be squeezed up, say a skeletal muscle contracting, putting pressure on the vein, pushing the blood up, but then if the valve doesn't close all the way, the blood's going to flow back down. And then it'll be squeezed up again, and then it's going to flow back down. It's not going anywhere. And what will happen is you're pumping more and more blood in from, say, lower in the leg, and then it gets to the spot where there's this bad vein, and it can't really make it past that spot. So what's going to happen? Well, you're pumping blood into this section, but you can't pump it out. So the vein is going to get larger and larger and larger, and it's going to stretch out. And that valve is going to work even less because those flaps are going to get further and further apart. So as that vein gets larger and larger, fills up with blood, you get something called varicose veins, and you can see that here. And not only are varicose veins kind of unsightly, but they can cause things like dermal atrophy, hemorrhage, ulceration, and cellulitis, problems with the cells around those veins. And here's a really bad case of a very large varicose vein where the blood just can't flow through it very well. So it continues to stretch that vein out. And that's why you get this sort of wiggly pattern, because not only is it getting wider, but it's kind of stretching it out and getting longer, kind of like a river, how it sort of zigzags through flat area where it can't flow very quickly. So varicose veins are caused by a problem with the valves in the veins. So those valves don't close properly and the blood can't flow properly through those veins. Okay, so I'm done with my little tangent now. All right, so let's go back and look at some peripheral vascular terms. Arteriosclerosis. All right, let's break this one down. Arterio means we're talking about arteries, and sclerosis means a thickening or a stiffening of those arteries. So arteries tends to be really flexible, especially when you're young. They're really flexible, and every time the heart beats, they expand as they fill up with blood, and then they sort of squeeze down, and then they expand again, and they squeeze back down. So they're real stretchy. Now, if they become sclerotic, if they become stiff, they're not going to expand so much, and that's going to be a problem. Now, a couple of reasons that can happen. One, in smaller arteries, you can get like a little calcification. You can sort of see it here, these little arteries that have sort of calcified a little bit. The calcium is built up in the arterial walls, and that's going to cause them to stiffen up a little bit. But normally when we think about stiffening arteries, we're thinking about atherosclerosis. Now notice that's a little bit different than arteriosclerosis. Arterio meaning any kind of stiffening of arteries. Atherosclerosis is we're talking about fatty deposits in the artery. So atherosclerosis is specific to the fatty deposits that happen in the arteries. And this happens especially with high blood pressure. The higher the blood pressure, the more likely this is going to happen. So you have the tunica intima, that thin layer of smooth tissue. And what will happen is if you have really high blood pressure, you can have a little fat particle, a little cholesterol particle, and it gets pushed through that wall, that tunica intima, and it sort of gets stuck behind it. So it gets stuck between the tunica intima, that inner layer, and the tunica media, the muscle layer. So that little piece of cholesterol, that little piece of fat sort of gets stuck in there. And then as this process continues for years and years and years, and this usually begins, say, when you're 15 or 20, and you start to get this build up, and it builds up and builds up very slowly until you're 50, 60, 70 years old. And what happens is more and more of these pieces of fat get stuck in this artery wall, and it builds up and builds up, and it makes it narrower and narrower and narrower. So here's what happens. As it gets narrower and narrower, and the blood's having trouble flowing through there, now the blood's got a narrower passage, it's got to flow through faster. So it's got to have even more pressure. And it's going to start to abrade. It's going to start to cause abrasions along that tunica intima, that very smooth lining of the artery. And when that happens, you can start getting little pockets where blood clots can form. So here's the process. You very slowly, over years and years and decades, you slowly narrow these arteries as you build up fatty deposits in the artery wall. And then it gets to a certain point, right about here, let's say. And after many, many years of very, very slowly building up, you start to get those abrasions, and you get a blood clot that forms in this little narrowing. And all of a sudden, that narrowing that took years and years and years to get to this point can close off the rest of the way with a blood clot in a matter of hours or even minutes. So things that get slowly, slowly, slowly worse can all of a sudden instantly go to really, really bad. Blood flow is cut off completely to everything downstream from that clot. So atherosclerosis is that very slow buildup of fatty deposits between the tunica intima and the tunica media, the muscle in the artery wall. And here you can see a cross-section of what that looks like. That yellow, that fatty deposit cholesterol, it's essentially butter. That's what it is. These fatty deposits are essentially butter that fills up inside the wall of that artery, making it more and more narrow. So where does this happen? Well, if you just got a straight shot of an artery running along, there's no point where there's going to be higher blood pressure or lower blood pressure. So there's no real point along that artery where this is going to build up. But let's say now that you have a fork in the artery, and there are many, many forks in an artery. And at that point, the blood has to come down and it's got to, wait, which way do I go? Do I go this way? Do I go this way? It takes just a minute, okay? It's not really thinking about it, but it does sort of slow that blood down a little bit. So here you've got this blood flowing along and all of a sudden it slows down. What do you get? Well, you get a little spot of high blood pressure, higher than the rest of the system, because it's slowing down as it decides which of these branches it wants to go down. So at these branches, you tend to have slightly higher blood pressure than you do in the rest of the system, which means you have a slightly better chance of this fatty buildup to form at branches than you do along a straightaway. And if you have this narrowing and all of a sudden a blood clot forms in that narrow spot, and if it happens in the heart, that's a heart attack, where the blood flow is cut off to the heart muscle and the heart muscle starts to die. If this happens in the brain, this is a stroke. But this narrowing can happen in other places as well. It can happen in the legs fairly often. And in this case, you're probably not going to necessarily get a blood clot so much, but you are going to get a narrowing, which is going to reduce blood flow to those legs. And when that happens, you have a condition called claudication. So claudication is where you have a narrowing of those arteries in the legs. Blood flow is greatly decreased. The muscles in that area are not getting the nutrients. They're not getting the oxygen that they need. That's claudication, and it's a very painful condition in the legs. A good way to look for these narrow spots in arteries is to do an angiogram. Now we're going to go through a couple of terms here that kind of sound similar, but there's slightly different meanings. So an angiogram, angio, we're talking about any blood vessel, and gram means we're taking a picture of it, we're looking at it. Okay, so we're going to get an image back. So an angiogram is going to be an image of any blood vessel. A slightly narrower definition is going to be an arteriogram, where we're going to get an image of an artery as opposed to a vein. Okay, so an angiogram is all blood vessels. Arteriogram is arteries. And then you could do an aortogram. And in this case, we're looking very specifically at one artery, which is the aorta. So we can do an aortogram looking at the aorta. Now, to do any sort of angiogram, we're usually going to inject the blood vessel with some sort of contrast media. Now, what the contrast media is going to do is it's going to block x-rays from going through. So we're going to use an x-ray machine, a fluoroscopy machine. We're going to look at the blood vessels, and we're going to inject this dye, this contrast media through it. It's going to block it. So you're going to see where the blood is. You're going to see a map of these arteries. And when we do an injection of contrast media, we're usually going to use a glass syringe. Those plastic syringes that you usually see, usually not good enough, because what we want to do is we want to avoid bubbles. Any kind of bubbles, we want to avoid those. Why? Well, because x-rays can go right through bubbles, and we're trying to create a contrast in there. So if we were to happen to inject a couple of little bubbles into the artery, then we're going to see this little spot there on the angiogram. So we're going to see something on the angiogram. We're going to think, oh, there's a stricture there. There's a narrowing there. And really, it's just an air bubble. So we want to make sure no air bubbles get into this. And that's why we're going to use a glass syringe, because glass syringes really help reduce the number of air bubbles that we're going to get in there. Now, two surgeons have really sort of pioneered cardio and vascular surgeries, and these are DeBakey and Cooley. And DeBakey, obviously, he has the little forceps named after him, those atraumatic forceps. So a DeBakey forceps is atraumatic because you can pinch down on the blood vessels without causing damage. So DeBakey and Cooley are two surgeons that have done a lot of pioneering work in cardio and vascular surgery. So the first surgery we'll talk about is an angioscopy. Now, an angioscopy, different from an angiogram was just sort of taking a picture, an overall picture using an x-ray, essentially, of the blood vessels. An angioscopy, kind of like a laparoscopy, we're using a scope. We're going to go inside and look around. So an angioscopy is we're going to insert a little scope into the blood vessel and look around and see what's going on inside that blood vessel. Now, usually this is done on much larger blood vessels. If the blood vessels get too small, our scopes have trouble getting that small, and we don't want to put in a scope that's bigger than the blood vessel itself. It's going to cause some problems with the blood vessel, obviously, if we stretch it out. So usually we're looking at larger blood vessels when we do an angioscopy. So an angioplasty means we're going to go in and fix or change something about that blood vessel. And often we'll do an angioplasty with something like this, which is a Fogarty catheter. Now, a Fogarty catheter is this long, thin tube, and notice it has this little balloon on the end. And it's that balloon that we're going to use to expand the blood vessel. So let's say we're going to do an angioplasty on the heart. We're going to do a cardiac catheterization. We're going to go in to the coronary arteries of the heart and try to fix those. If they have a little narrowing, we want to open those up. So we're actually going to make the entry down in the leg, down into the femoral artery, and that's where we're going to cut down, find that femoral artery, and make our incision there. We're then going to insert our catheter at that point, run it all the way up through the aorta, into the heart, into the coronary artery, extend the catheter a few centimeters, 1 or 2 centimeters past this little narrow point. And then what we're going to do is we're going to inflate the balloon. And what that's going to do is it's going to cause that narrow area of the blood vessel to expand. We're going to stretch it out. And when we release that balloon, hopefully the vessel is going to stay open and the blood's going to be able to flow through. And this is really an amazing procedure. Usually what you're going to have is you're going to have somebody come in with chest pains. They're going to be having what feels like a heart attack, and it kind of is. All right, so they're having trouble breathing. They're feeling weakness. Maybe they fainted, something like that. They're really going to be feeling very, very bad. You're going to go in, insert this balloon, expand it, and as soon as you withdraw it, the blood starts flowing to that area like it hasn't probably in years, and instantly the patient feels better. The patient's like, oh my gosh, it's like in seconds. They're like, wow, I feel so much better. I'm ready to run a marathon kind of thing. That's how much better they often feel after a cardiac catheterization. So there really are some impressive results that you can get from a balloon angioplasty. Now, if the blood vessel happens to be really thick or maybe really stiff and it doesn't stay open after we've inflated the balloon and it sort of narrows back down, or maybe something's putting pressure on it or something, we can insert not just with the balloon, but we can insert a stent, which is just a wire mesh in a circle, and it's going to open it up and it's going to help hold that blood vessel open and allow the blood to flow through. So putting a stent in there is going to help keep that blood vessel from collapsing back down to where it was before. A central venous catheter, or a central line, is putting a catheter not into an artery, but into the vein, and we're going to run that catheter all the way down to the heart itself. Now, in this case, we're not trying to fix anything that's wrong with the vessels or the heart itself. Instead, what we're doing is we're creating a port. We're creating an access point to get things into and out of the bloodstream. So for example, one of the things that we can do is use this to inject chemotherapy. Let's say the patient is having cancer treatment, they're getting chemotherapy, and these chemotherapy drugs can be kind of rough and they're kind of tough on the veins. So what we're going to do is we're going to put this catheter in and bring it all the way down to maybe the vena cava or the heart itself, where when we inject that drug into the system, it's very quickly diluted and doesn't cause nearly the problems that we would if we put it in a small vein where it would be very concentrated. We can also use a central line to inject things like IV fluids, or maybe do dialysis where we're filtering the blood. We can use a central line for dialysis. We can do transfusions. Blood transfusions can be done through a central line. Or even if we want to take blood samples, let's say we have to take a blood sample over and over and over again on the same patient. Well, instead of sticking them over and over again constantly and hurting them, we're going to put in a catheter one time, and then we can just pull the blood from this little central line catheter and take our blood samples that way. So these central lines provide an access point. We don't have to keep sticking the patient over and over again. We can use this same existing central line to inject drugs or take blood samples. And what they do is they reduce burning and scarring of vessels. Instead of injecting these harsh chemicals in, say, a small blood vessel, we're going to inject it into a large one where it becomes dilute very quickly, and that helps prevent burning and scarring that could otherwise happen. And there are several different ways of doing a central line or a central venous catheter. A short-term version is going to be a percutaneous. Percutaneous is you're going through the skin, and this is going to be a non-tunneled, and I'll get to what that means in a moment. So in this case, we're just going to go up here, usually just under the clavicle, and inject into the subclavian vein and put the catheter in, and we're going to keep it there for maybe a few hours or a few days, and that's where it'll stay for just a short period of time as we're doing our tests. But if we have a patient who's going to need a central venous catheter for a longer period of time, let's say weeks or months, what we're going to do is we're going to use a long-term indwelling catheter or a tunneled catheter. And we're doing essentially the same thing. We're taking the catheter, we're running into the vein down to the heart so that we can inject the medicine all the way down there where it can be very dilute. But instead of having it come out here at the clavicle, right where the vein is, we're going to actually tunnel it through the skin, through that chest wall, and down and have it come out closer to the sternum. And what this does is it helps fix it in place. So anytime we go in to access it or tug on it a little bit, we're not pulling on that vein itself. We're pulling somewhere down here where it's going to be attached to the skin, and we're not going to cause any damage to the vein way up here. So that's a tunneled catheter. We're tunneling it under the skin before it enters the vein. And examples of this type of catheter are going to be the Groshon catheter, the Hickman line, or the Broviac. And most of these, especially the Groshon, has 2 lumens. So you can both inject and withdraw fluids at the same time. But another option for a longer-term central venous catheter is instead of tunneling it through the skin under the chest wall, we can actually run it down the arm, for example, and into a peripheral vessel. This is going to be a peripherally inserted central catheter, or PICC line. So PICC, peripherally inserted central catheter, PICC line. And for patients who need a catheter such as this for long term, but it doesn't necessarily have to be used very often, but they still want to keep it there because they're going to need it for a long time, we can insert an IVAD, an implanted venous access device, an IVAD, or a port, such as a portacath. Now in this case, we're inserting the catheter, and instead of having it extend out of the skin somewhere where we can access it, we're going to put this little port just under the skin. So the port's going to go under the skin, and the skin will heal over and it'll just be waiting to be accessed. So this way, if we do have to access it in order to inject some medicine, let's say, instead of injecting into the vein all the time and causing damage to the vein, we're going to inject into this port, which is going to take the brunt of that sticking, and it's going to then lead it down into the vein. So we're sparing the vein by using this port instead. And just for clarification, these central venous catheters are a little bit different from, say, an arterial line. Obviously, the main reason is we're going into a vein instead of an artery. But with an arterial line or an A line, usually we're not going all the way up to the heart. Usually we're just going into an artery. And this is sort of a procedure. Installing an A line can be done by doctors at bedside, or even some nurses can install an A line. So unlike with a central venous catheter, a patient getting an A line doesn't necessarily have to be taken to an OR and go through a big procedure. An embolectomy or a thrombectomy, again, we talked about embolus and thrombus. So a thrombus is going to be a blood clot that's stuck on the inside of a vessel, and an embolus is going to be one of those that breaks away and it's sort of free floating. So that's the difference between an embolus and a thrombus. And if we want to go in and then remove that embolus or thrombus, that's going to be an embolectomy or a thrombectomy. Now again, usually that embolus is going to flow through the system just fine until it gets to a point where the blood vessels get smaller and smaller. It's small enough where it suddenly gets stuck. So that's the point where we want to go in and get it out. So what we're usually going to do is we're going to make an incision a little bit upstream, insert a catheter down past that embolus, inflate a balloon, and then we pull the inflated balloon backwards, catching that embolus with it, and pulling the embolus and the balloon out through the little incision that we made. And again, we can use a Fogarty catheter, that catheter with the balloon on the end, to do this kind of procedure. Now, the carotid arteries are the arteries that go through the neck leading up to the brain. We have the common carotid artery, which then branches to an internal and an external carotid artery. And as I said before, where you have a branching, that's where you tend to get that plaque, that fatty buildup. And that often happens here at that branch point between the carotid, the common carotid, and the internal and external carotid arteries. Now we're talking about blood flow to the brain in this case, because that carotid artery leads up to the brain and feeds the brain. So if we have a narrowing or a blockage in that carotid artery, that's going to cause a whole lot of damage, really bad damage, really fast. Now, fortunately, the body actually has a little lifesaver. You know what a lifesaver is, that little circular candy. It's got a little hole in it, right? So sort of this round circle, that's a lifesaver. Well, the brain has a lifesaver, and it's called the Circle of Willis. And again, whenever you hear a term like that, you know it's going to appear on a test somewhere. So the Circle of Willis is a circle of arteries around the base of the brain. And here's what makes this circle such a lifesaver. The circle is fed by the internal carotid artery from either side, and then from there, it branches out and feeds the rest of the brain. So if there's a clot in one of these arteries, if this side gets blocked up, this side's going to continue to feed, and because of that circle, it's going to feed all the way around to the other side and continue to feed those blood vessels on this side as well. So it's not quite as good as it was before, but if there's a complete stoppage of blood on one side, because of this circle, it's able to send that blood around to the rest of the brain and keep the patient alive. And that's pretty cool. But even though the patient's still alive, it's not the greatest situation, so we still want to go in and fix this. So we're going to do something called a carotid endartectomy. And an endartectomy means we're going to go in and make an incision and surgically remove that plaque that is built up in that artery. And by doing this, we're going to help reduce the number of transient ischemic attacks, or TIAs, which is a type of stroke. Now, whenever we open up an artery, that means blood flow is going to be affected in some way. So what we're going to do in this case is we're going to use a shunt. We're going to clamp off the artery briefly, make an incision, insert a shunt in this end and this end of the artery, and then seal off both ends around that shunt. And what that's going to do is it's going to allow the blood to flow into the shunt, through the shunt, and then back into that artery past where we've made the opening. So now that the blood is shunted around where we're working, we can go in there and work on removing that plaque that is built up in that area. A common instrument that we'll use in one of these surgeries is the freer elevator, which has the smooth tip that lets us get in there and sort of work around this plaque and eventually loosen it and pull it away. The types of shunts that we can use, we have just a plain old shunt that I'm showing here, in which case we've used a vessel loop to tie around both ends of this shunt to keep the blood flowing through the shunt and not out around the shunt. But there's also a special kind of shunt called a Javid shunt. And in this case, the Javid shunt has these little balloons, these little balls at each end of the shunt. So as we insert that in there, we can then use a Javid shunt clamp, which is going to clamp around these little balloons, sealing that blood vessel off. And this is usually done a little bit quicker than using the vessel loop. Some doctors like one, some doctors like the other, so you'll probably see it done both ways. But the key here is that the Javid shunt has these little balls on each end of the shunt itself. Now, once we've removed the plaque, we're going to patch the vessel and close it up using something called a Dacron patch. In this case, you can see one here where Dacron, an artificial material that we're suturing into place over the wound that we created to help seal that blood vessel. An aneurysm is when a blood vessel, usually an artery, because they're the ones that are under pressure, sort of gets a weakness in the wall and sort of bulges out or stretches out. It gets this big bubble in it. And if it stretches out too much, that wall is going to get really, really thin and could burst. And if it bursts, that's going to cause a lot of problems. So if our scans tell us that our patient has a cerebral aneurysm, one of these bulging sections of artery in the brain area, cerebral aneurysm, we can go in and do a procedure where we clip the aneurysm. And basically all we're going to do is take a little clip, pinch it around the base of that aneurysm or base of that bubble. That's going to seal that off so that even if now the bubble breaks and it starts to leak, we've now clipped it off, and that's going to protect the blood and not allow it to flow through that opening. So moving away from the head, we're going to now take a look at the aorta, which feeds most of the rest of the body, especially areas below the heart. The aorta extends down through the trunk of the body until it breaks and goes towards each leg. Now, from the aorta, we have several arteries that sort of branch off of that. One of the first branches we have is the celiac artery. That's going to feed the liver and the stomach, things like that. We have the superior mesenteric artery. Now, the mesentery is sort of a fold in the peritoneum that spreads out and feeds blood vessels to and from things like the small and large intestine and a few of the other organs in the abdominal cavity. The renal arteries break out from there. They go to the kidneys. A little bit below that, we have the inferior mesenteric artery, and this feeds part of the mesentery that hits the descending and sigmoid colon. So the inferior mesenteric artery takes care of that part of the colon, the large intestine. And then eventually it splits into the two iliac arteries headed down into the legs. So as you can see, the descending aorta is a really important artery. And because it's so close to the heart, it's containing so much of the blood that comes out of the heart, it's under a lot of pressure. That's where the blood pressure is the highest in the aorta. So what can happen is sometimes there can be a little weakening in the walls of the aorta, especially down towards the split with the iliac arteries, and that can cause the walls of the aorta to bulge out and stretch out. And this will happen in a lot of patients, and they won't even know it because who can tell that there's a little bulging going on in the aorta. But if this bulging gets too severe, these walls can become very thin, and it puts the patient at risk of a rupture. And if the aorta ruptures, that's going to be a very, very bad situation. So this bulging is an aneurysm, and in this case, we're talking about an abdominal aortic aneurysm, or a AAA. And one way to repair this is to use a stent graft, where we're going to insert an artificial stent through this aorta up to the top and attach it to the top part of the aorta where it's okay, run it through the bulging, the aneurysm area, and then down into the iliac arteries and attach it down there so that the blood flows through this graft instead of through the aorta itself. So even at this point, if the walls of the aorta do break down, the blood's still going to continue to flow through this graft and stay contained and keep the patient alive. And timing this procedure is key, because if we wait until the aneurysm actually ruptures and the patient starts to bleed, even if we go in and try to put this stent in very quickly, we still have an 80% plus chance of mortality, meaning more than an 80% chance that the patient's not going to survive because of so much blood loss. But if we put the stent in before the aneurysm ruptures, then the mortality rate is reduced to 2 to 3%. Yeah, there's still a risk, but it's much smaller than waiting until after the aneurysm bursts to put this stent in. Now, if the aneurysm happens down in the iliac arteries, we can do something called an aortofemoral bypass. And in this case, we're going to take a graft, attach it to the abdominal aorta, bring it around, branch it around, and then attach it down at the bottom to the femoral arteries, bypassing the iliac arteries entirely. This can also be done if there's significant blockage in the iliac arteries. If the blockages are further down the leg in the femoral artery, we can do a femoral-popliteal bypass, or a FemPop bypass. And in this case, we can use the saphenous vein, which is also found in the same area, to use as the bypass graft. So the idea of using veins to replace arteries seems like an obvious choice, but then you have to remember there's a difference between veins and arteries. Remember, veins have these valves in them and arteries don't. So if we want to use a vein as an artery, we have to get rid of those valves so that the blood pressure will push the blood through rather than the valves sort of stepping the blood slowly through that vein. So we're going to do something called vein stripping. Now, to explain vein stripping, I've got my sock again and show you what's going to happen. So here we have the sock. This is our saphenous vein. And again, all the valves are on the inside of the saphenous vein. But we don't want the valves there. So in order to fix this, we're going to turn the sock, turn the vein inside out. We're going to make a small incision at this end of the vein, a small incision at this end of the vein. And we're going to take an instrument and insert it all the way through the vein, grab one end of the vein, and pull it all the way through until we've turned the vein inside out. Now look what happened. See all these little fuzzy things? These are the valves that were on the inside. They're now on the outside of the vein, which means blood can flow through the inside of this sock or the inside of the vein very easily. So vein stripping and ligation is turning that vein inside out, so the valves are now on the outside and they're not blocking the blood flow. Now, we talked about DVT, or deep vein thrombosis, where the blood sort of clots in the veins of the legs if you're sitting in an airplane or something like that. But also, patients can just have blood clots form naturally for other reasons, maybe just because the blood's flowing a little slower than it otherwise would, not necessarily because they're sleeping in an upright position. So if you have a patient with a lot of blood clots, or maybe with DVT, a really bad case of deep vein thrombosis, one of the ways of protecting the patient from embolisms, which is when one of these clots sort of breaks off and starts floating through the venous system, is to put a vena cava filter in place. And here you can see these filters come in all kinds of wild shapes. And what we'll do is we'll use a catheter to insert this filter into the vena cava, deploy it, and let it fix in that position. And it's going to sit there and catch anything that happens to float through. So if you have a big embolus that sort of releases and flows through, it's going to be caught in this filter and it's going to sit there in the vena cava. Now again, this embolus is going to be smaller than the diameter of the vena cava itself, so it's not going to block the whole thing. And it's just going to sit there, and it'll probably sit there for a few hours to a few days, maybe a few weeks, and very slowly the body will sort of break that embolism down and into these little pieces and sort of take it away. So the filter will be there catching any of these little emboli that happen to work their way up, and the body will eventually break them down, keeping that blood flowing through the vena cava. And the last procedure we're going to discuss is one that you'll probably have a good chance of seeing during your clinical time. This is an arteriovenous fistula, or an AV fistula. Now, a fistula is a connection between two vessels. So in this case, we have an artery and a vein. That's going to make our arteriovenous fistula. So we're going to make a connection between an artery and a vein. Now, why would we do this? Well, remember, blood pressure in the artery is high, and the artery is able to take that blood pressure because it's got a nice thick arterial wall. The vein, not so much. So if we put blood pressure, arterial blood pressure into the vein, it's going to cause it to stretch out, kind of like, those varicose veins. So we're kind of sort of creating a little varicose vein in the arm of the patient. Well, why would we do that? Why would we want to create this really big vein in the arm of the patient? If this patient's getting dialysis, which means they're coming into the clinic several days a week for this long procedure, and they have to get not one, but 2 needles placed into this vein, finding a tiny little vein to do this over and over and over again is going to be really challenging. So we make this AV fistula, which is going to make that vein much larger, which means it's going to be much easier to put these needles in there to allow the blood to flow out to the dialysis machine and back into the body. Now, sometimes this is done by making that vein larger and makes it easier to get those needles into it. But a more modern way of doing it is to use a synthetic bridge graft, which means we're going to connect the artery to the vein through this synthetic material, which means on dialysis days, we're going to take our needles and stick it into this synthetic material rather than into the patient's vein itself, which is going to cause a lot less damage to the patient. So that's a preview of peripheral vascular surgery. I hope you learned a lot. I enjoy talking about this stuff, and I'll see you next time.